So I'd like to get us started with some brief introductions. My name is Yordanos Waldemariam, and I'm a Senior Project Manager with the Canadian Institute for Social Prescribing, which is an intersectoral collaborative of the Canadian Red Cross. Before we begin, I'd like to take a moment to recognize the traditional land from which I'm joining you all today. I have the privilege of joining you from the ancestral and unceded homelands of the Hunkaminam and Squamish-speaking peoples. I welcome each of our attendees to share their respective land acknowledgements as well in the chat.
Que ceux qui sont présents, j'aimerais bien qu'ils partagent.
Perfect. And before we get started, we have a wonderful panel here for you today with leaders in social prescribing from Ontario, Manitoba, and British Columbia. And I'd love to pass it off to the panel for a brief introduction. So over to you, Connie, to introduce yourself first.
Good afternoon. I'm Connie Newman, Executive Director, Manitoba Association. Manitoba, we acknowledge that Manitoba is the homeland of the Red River Métis, and we respect all the treaties.
Wonderful. Thank you, Connie. And over to you, Dina.
Thank you. Hi, everyone. Thank you for joining us today. My name is Dina Silverberg, and I'm the project coordinator for the Links to Wellbeing project, part of the Ontario Older Adults Association of Ontario.
Wonderful. And to your colleague, Dina, Pat, if you'd like to go next.
Hi, everyone. I'm Pat Spadafora. I'm a consultant in Ontario, and I have the very good fortune to work with Dean and others on the Links to Wellbeing project.
Wonderful. Thank you, Pat. And last but not least, we have Bobby.
Hey everyone, my name is Bobby Symes. I'm the Director of Healthy Aging at United Way, British Columbia. And I actually have the privilege of sitting right next to Yordanos today. So welcome, everybody. Thanks for being here.
Perfect. All right. Well, we are going to get started. We have lots of information to share with you today. And we're going to have Connie start us off with a presentation on social prescribing in Manitoba with a focus on collaborative impact.
And over to the slides, please. Go. Those aren't my slides. I'm not sure what we're going to do. How about Pat or Dana go first?
Is that okay, Dina and Pat? Are you okay to go first since your slides look like they are advancing?
Sure, we can do that.
That's fine.
It looks like the slides were out of order.
Perfect. Thank you.
It's okay. We're all flexible people. So thank you. So Connie, we'll switch it over to you afterwards. So thank you, Yordanos, and thank you to my amazing co-presenter. Thank you for joining us today. I'm going to be presenting with Pat Spadafora about the Links to Wellbeing project, which is a social prescribing project for older adults in Ontario. And we're going to be discussing some of our positive impacts, greatest learnings so far, and we're going to be sharing a wonderful video with you. Next slide, please. So today's topics, I'm going to be explaining a little bit about what the Older Adult Centres Association of Ontario is, a little bit about senior active living centres, what exactly is Links to Wellbeing, our social prescribing project for older adults, the building pathways between clinical and non-clinical supports, how we're building referral sources. Pat is going to be highlighting some of our data highlights, our results, our impacts so far, and going to be introducing and sharing our video, which we've been using for outreach for the past year. Next slide, please. So what is the OACAO? For those of you who are not familiar with the OACAO, the Older Adult Centres Association of Ontario is a recognized leader in the development of quality services, resources, and support for our network of community-based older adult centers. The OACAO provides advocacy, education, networking, and resources to support a network of over 230 community-based older adult centers. And we're still bringing new centers on board as well, and seniors serving organizations across the province. OACAO has really been the voice of older adult centers and senior active living centers across the province, and really helps to bring their voices forward and helping older adults stay connected in the community. And it's also my pleasure to share that this is our 50th anniversary year, and we're very excited. For an organization that started around a kitchen table 50 years ago, we're now all across Ontario. Next slide, please. So the Links to Wellbeing Project. The Links to Wellbeing Project is a social prescribing project for older adults in Ontario, and the overall purpose is to support older adults who might face negative health impacts from social isolation and a lack of or limited connections to social and recreational opportunities. Next slide, please. So the Links to Wellbeing Project, we're halfway through year 2 of our 3-year project right now. And we had 3 primary objectives when we started off the project. The first one was to really create intentional health social pathways between primary care providers and senior active living centers. And this has been lost in the last 3 years, especially during COVID, where there's been a lot of staff turnover, volunteer turnover, and it's really been going back to those grassroots connections and bringing community together with their healthcare providers, with their senior active living centers, so there's connections in the community. The second primary objective has really been to improve the understanding of non-clinical interventions on well-being and service utilization through data collection and evaluation. As part of the Links to Wellbeing Project, we are collecting data on each individual that is referred for a social isolation, a social prescription. We're collecting information at intake. We're collecting information at 6 months and 12 months, and we're asking the same questions, and we're using that data to not only demonstrate the benefits of belonging to a senior active living center, but the benefits of social prescribing. And the third objective was really to develop and deploy infrastructure for national level scaling and learning about social prescribing. And we're so excited now that there is CISP and there's a Canadian organization. When this started off, there wasn't. We now have an Ontario community of practice. We have a Canadian community of practice. And all of these opportunities for people to learn from each other and keep growing the message of social prescribing. Next slide, please. So what is a senior active living center? I know there's still a lot of myths, and I know it's different across different provinces, but a senior active living center is especially unique. And I always like to say, if you've been to one senior active living center, then you've been to one senior active living center. The beauty of each senior active living center is that they're each distinctive in their programming, their geography, their people. I worked for a seniors organization in Toronto for 25 years. And at that organization, we had 2 senior active living centers. One of them catered to a very different population. And then when you crossed over a major intersection, I was offering programming in different languages. It was unique to that community and to the programs and services they were offering. And that is really the beauty. You can refer to multiple senior centers because each senior center has something different to offer. And just like each senior center has something different to offer, each social prescription is unique to the older adult, and their social activities are based on what matters to them most. So unlike a prescription for a medical prescription or for a different something that is prescribed by a doctor, this is specific that the older adult gets to choose. Yes, it's a social prescription, but they get to choose once they go to the senior active living center. Would they like to participate in a social group? Would they like to do exercise? Do they want to learn how to play bridge? Do they want to participate in current events? It's their choice, and that's what drives the prescription. Next slide, please. And now I'm going to turn it over to Pat.
Yeah. Thank you, Dina. Thanks so much. Hello again, everyone. I got bumped out of Zoom momentarily, but thank you, Dina. Dina, you really made me think when you were talking about CISP and the Ontario Community of Practice and the Canadian one. We are halfway through year 3 of a 3-year project. And when you spoke about that, it made me think of how far we have come in the last few years. So social prescribing is really gaining very solid traction in Canada, and I think that's quite exciting. What hasn't changed a lot is the referral pathway that we use in the Links to Wellbeing project. This has stayed pretty much the same throughout the length of the project, although you will see that the people who are referring have changed. But this is generally what we follow. The SALCs that Dina mentioned, primary care providers and other health professionals connect in the community. The PCP, I'll use the acronyms, identify clients or patients. A SALC, just see a question in the chat there. The SALC is the Seniors Active Living Center that Dina spoke about, and the VLA is the Volunteer Link Ambassador. Okay, so back to the pathway, the primary care provider identifies a client or a patient, whatever term they're using, that they think may benefit from a non-clinical intervention, might benefit from participating in the SALT, and literally writes a social prescription to that local SALT. I'm sure Dina or I would be happy to share the specific tools that we've developed over the last 2.5 years with you, if you would like to take a look at them a little bit more closely. The SALC then receives that social prescription, and a designated center contact will connect the older adult with a volunteer link ambassador. The volunteer link ambassador, the VLA, meets with the client and connects them with programs that they're interested in at the SALC. I should point out, though, that in some situations, it's the staff person. It's not always the VLA. It varies a little bit by the center. And then the lessons learned from the data that we've collected that Dina mentioned, we can circle that back because we take that to really improve services even more. Next slide, please. I mentioned that these pathways, and I want to really highlight that they're intentional pathways. One of the things I've heard throughout the day with these wonderful presentations has been the fact that many organizations have always been doing something related to social prescribing, even though they might not have called it that. One difference that we're seeing now is this is very intentional. It's something that we can track and something that we can use to benefit older adults and to increase really the services that are available to them. You'll see a list there of some of the pathways that we've created through Links to Wellbeing. It changes all the time. This is just, these are some examples. In the North, for example, community paramedics really came on board not that long ago. Well, maybe it was a year now. Time flies, right? But they, that's been fantastic. And we're working more and more now with pharmacists and others, community health centers, of course, family health teams, solo physicians. It's really, there's another example. I keep thinking of the Pope-mobile, but what it is a nurse mobile. It's a traveling nurse clinic that has been instrumental in referring their clients, patients as well. So you'll see it's quite a range of people. One that you might not see on this list, but I'm going to reference in a couple of slides, are the local branches of the Canadian Mental Health Association. So I'm going to now focus for just two slides on a little highlights of the data and a little bit about the evaluation and impact. So if I could have the next slide, that would be fantastic. Thank you. We've heard this throughout the day too. Major barrier to participation reported by the clients was cost and transportation. Transportation seems to be a persistent, complex problem in Canada, something that we've been hearing about for a long time. Over 47% of the clients that are involved in the Links to Wellbeing project do receive subsidies that can support program fees and or transportation. So that's a pretty high percentage. Excuse me. These are the major reasons that clients have been referred to the SALCs. Isolation, not surprisingly, and loneliness are right at the top there. Mild depression, and then the other 20% are people who are being referred to develop social skills, explore their interests. Just before you move to the next point, I just want to highlight something that you would see on the referral form. And that's the fact that if somebody's requiring clinical intervention for more severe depression, for example, then we make sure that referring parties know that, and that referring to the SALC may not be the most appropriate route, but the SALT can also refer on to other organizations as well. Next, please. I think this is a really important point. We tend to think that people who are lonely or isolated live by themselves, but really 45% reported that they live with others. So you can be living in congregate living or in a family situation or with a spouse, and you can still be impacted by social isolation and loneliness. Next slide, please. And here, I just wanted to share with you some of the results and impact. We now have over 80 seniors active living centers that are involved in the project, 18 community health centers. We've received 753 referrals. You'll see the source of the referrals at the bottom left quadrant, community health centers, family health teams. I'm going to point just one other thing out, and Dina, I don't think we're going to have time to show the video, but the video is in the conference. I don't know what, I'm not exactly sure where it is there, but I saw it somewhere else within the conference and people could look at it there. I just want to highlight one story because it's really stories trump data every time. And that came from that Canadian Mental Health Association branch I mentioned. And she is saying that this really just struck me. She said very definitively that one of her clients went from absolutely no socialization to now participating in SALT programs 2 or 3 times a week. And this particular case manager, whom I interviewed last winter, said that she's confident that it's the social prescription and the subsequent experience at the Seniors Active Living Center that was the primary reason for her being able to discharge that client. So I think that's pretty powerful. Dina, I think we've run out of time. So we'll have to either show the video at the end if there's time, or we'll have to show it. People can look at it elsewhere on the site.
I think so. I was just in the chat box with our amazing team, and it looks like we're able to show it, and then might just cut into a little bit of our QA time at the end.
Okay, I had a note saying
okay,
we only had a minute. Okay, in that case, the next slide, and you will get to see. So we wanted to end our presentation with you hearing the words of the healthcare providers, the centers, and most important, older adults themselves about the impact of social prescribing in their lives.
A lot of my patients were widows or widowers and lived alone. So I have been referring to the local adult center for a number of years now because both mentally and physically they have things to offer.
I was referred here by my nurse practitioner. Since I'm relatively new to the area and we had the pandemic, I basically was lost because it's just like dropping me into a new environment, not knowing anyone.
Social prescription is a holistic approach to healthcare, and it bridges the gap between clinical and social care. It provides like a nice pathway for primary care providers to link their patients to local community resources.
When they mentioned that they had line dancing on the schedule, I knew that was going to be my thing. I love the line dancing, and you know, when I leave here, it's like I'm kind of walking on a cloud because it's just a very pleasant experience.
When somebody comes through the social prescribing program, they are welcomed by the volunteer link ambassador, and this helps alleviate the stress of coming into a center by themselves, not knowing anybody.
You don't have to be lonely and isolated socially. There's resources and activities that a person can get involved with.
The community is phenomenal. I mean, I can say forever, I'm alive because of people from the community.
Ready? 1, 2, 3, 4. 1 and 2 and 3.
We have about 60 weekly programs, everything from pickleball and badminton to writing group and choir.
I try to connect them with programs that I think, you know, would be appropriate for their physical health, their mental health.
It's benefited me because I'm new here. And it's a really good way for me to get out and get more involved with the community.
And let's do a little kickback, lifting up that heel for a gentle kickback. Social prescribing really helps engage people, get people involved with others. And those kind of symptoms that they're coming into healthcare providers with are improved without medication or other types of medical intervention. Good work. 4 more.
We are hoping to develop new partnerships within the community to open the world up to socialization to those clients who really could use it.
In a review of health service usage, where social prescribing schemes were implemented, there was a significant reduction in GP appointments, unplanned admissions to institutions, and a reduction in prescriptions. It's an awesome service, and it's just something that family doctors have to get into.
If a doctor feels that somebody is lonely and needing social prescriptions, recreation centers are the perfect place to be.
Social prescribing is an excellent avenue for helping our community stay active, stay involved, and for both physical and mental health.
What a wonderful video, Pat and Dina. Thank you so much for sharing. I think in the interest of time, I think we'll pass it off and continue to advance the slides. And I think we have Connie up next, but just want to be sure. Just waiting for our AV team to share those slides for us.
Jordana, we're glad. Bobby, you might be next.
I think everyone's ready and on deck. I'll just give it a minute here. Okay, so it looks like there's just some issue with the slides. I'm going to see if I can share your slides, Connie, and get us going. Give me one moment. All right, can everyone see these okay? Perfect. All right, well, over to you, Connie.
All right, your next slide, go for it. Okay, social prescribing gives us in Manitoba an opportunity to reimagine how we connect older people to programs and services in the local community. And kudos to Ontario, because everything you saw in that video is replicated in some way, shape, or form in our 80+ member centers across the province. We are also connected to over 90+ age-friendly communities. There is myself, 10 consultants, and 2 support staff. We're living under the World Health Organization. All older Manitobans want to age in the right place, generally their own community. They want the ability to function, and they want access to resources, i.e. senior centers, and they want few barriers. Next slide, please. Oh, here we are. Age-friendly communities. We've been at social prescribing for just coming up on a year. And in Manitoba, we're using our age-friendly communities and our senior center groups as an underpinning for social prescribing. The 4 pillars out of age-friendly community, sport and health services, communication, social participation, respect, and social inclusion are part of a way we go. Next slide, please. Social participation in Manitoba, you can see on the screen. Focuses or connection. And the World Health Organization has told us that through our age-friendly communities model, we want the capacity to participate in formal and informal social life. And that depends on having activities offered to you, i.e. our senior centers, access to transportation and facilities, and of course, communication. Next slide. The model in Manitoba, when we first started this about 11 months ago, is what we call a top-down, bottom-up model. We today have met with, and I'm going to go at the bottom of this slide, the provincial government, 3 deputy ministers. We've met with the heads of the regional health authorities in Manitoba. We got 5 of them. We've also connected with provincial organizations that are important. Senior centers, but active aging in Manitoba, the Alzheimer's Society, Rainbow Resource Center, Association of Manitoba Municipalities, as well as the Manitoba Association of Administrators. We have connected through our age-friendly leadership with communities that indicate an interest and are tied to their age-friendly senior center. Oh, we've got phones ringing all over the place here. Sorry about that. Lost focus, sorry. Next slide, please. In Manitoba, we have a very unique model. Not only our senior centers, but our senior resource coordinators are funded through Manitoba Health. And that they are what I would call the linkages, our senior resource coordinators, especially throughout the province. They're the linkers, the mentors. They are the ones that assist today older adults in community to local supports. So as we move social prescribing forward, our big thing is connecting our senior resource coordinators, our senior centers to our primary healthcare providers. Next slide, please. We are a nonprofit group. Manitoba Association of Senior Communities has a board of directors, and it's provincial. Key elements of our project today, we have contracted with a Dr. Michael Rutledge. He was formerly a family physician. He was a lead in public health in Manitoba for several years, and he's a real believer in age-friendly and the local community. We've also contracted with Verena Menick, who is doing our research and valuation. Jim Hamilton has been with us for several years. He was part of the National Seniors Council. Next slide, please. Dr. Michael Rutledge and I have connected with primary healthcare providers in 4 communities to date. We've brought along in the last 2 meetings we had our senior resource coordinators. The information to primary healthcare providers has been awesome. They have told us as recently as this week, this is what we need. So a primary healthcare provider needs to know what's happening socially within communities. Our senior resource coordinators and/or our senior centers are that venue for non-clinical services in the community. Next slide, please. Today we are in Winnipeg, 2 communities in Winnipeg. There's Prairie Mountain Health. We are in Brandon and Killarney, Interlake Eastern at Selkirk. We've done connection with the senior center there, and Stonewall. We met with them recently. Southern Health Authority. We were recently in Steinbach, and Steinbach is a large city, and we've also included in that probably 5 to 6 other senior resource coordinators from small communities. Next slide, please. Through our primary healthcare providers, through our senior resource coordinators, our senior centers, they have to create a data report to their funder on a monthly basis. Today, social prescribing referrals are on that data report. Sorry about this. The other thing we've done, we've created an online resource on our MASK website for and we've also included on our targeting isolation website 2 learning modules, one on volunteers and one on the healthcare professionals. Next slide, please. The collaborative impact for providing care providers to community-based supports. We're hoping this initiative is going to maintain itself over many years to come. Our positive results so far are doing well. Next slide, please. Our referral form in our 4 health region is pretty similar. The one in Winnipeg has 12 senior resource coordinators connected in it. Our issue today are electronic medical records are by fax. Unfortunate, most of our senior resource coordinators do email via PDF, and that's our barrier today, but we're working on it. Next slide, please. There's my and I'm going to say right now, over to Bobby.
Perfect. Thank you so much, Connie. I'm going to quickly switch over the slides here, so bear with me for one moment. All right, and over to you, Bobby.
All right, thanks, Giordano. So nice to join all of you today at this exciting virtual event. I'm always happy to speak on the topic of social prescribing. I am Bobby Simons. I'm the Director of Healthy Aging at United Way BC. Go to the next slide. I want to start off by introducing you to Bevianne. Bevianne represents who our connectors, our link workers, our navigators support and work with on a daily basis. Bevianne was living her perfect life until one tragic moment when she lost her light. So Bevianne was a vibrant light of a person. She embarked on an incredible adventure of love that took her all the way from her home in Winnipeg to the sunny shores of California. It all started with a whirlwind online romance that led her to marry Walter, who became her soulmate. For more than 20 years, Bevianne embraced her American life with Walter by her side until tragedy struck in January of 2020. Walter lost his battle with cancer, leaving Bevianne utterly devastated with a heavy heart, and she made the difficult decision to return to Canada, settling into a small community in British Columbia, where a friend of hers lived. Yet Bevianne faced numerous challenges in resettling, with no income, no social network, or suitable housing to accommodate her wheelchair disability, she felt isolated and alone and grappling with her emotions. Bevianne bravely admitted, "It was so bad that I was suicidal." And I'm going to leave that there right now to resonate with you, but don't worry, we're going to come back to Bevianne and her journey. Next slide. So United Way BC's social prescribing, you can go to the next one, stems from a series of community consultations that were done through 2018. And what we heard over and over again was that collectively we needed to come together to find better ways to support people like Bevianne, who wanted to continue to live in their home and in their community. And after a year and a half of researching and reviewing programs internationally, nationally, as well as in BC, we were able to come up with find social prescribing. And then we advocated to our provincial government for funding. We expressed the importance of doing a demonstration project. And with that, we received funding to launch 19 social prescribing programs across our province. And these all started in 2020. Next slide. So from start up until March 2023, the social prescribing program served a total of 2,554 older adults. We've seen a range of facilitators that contributed to the successful implementation and delivery of these programs. So things like physician champions, communities of practice, strong pre-existing relationships within the healthcare system. As well, we saw challenges, things like limited capacity of family physicians, lack of knowledge around the term social prescribing, as well as lack of community resources or a shortage thereof. So over the past 3.5 years, some of the outcomes that we've seen as a result of social prescribing, and this is common to what we're seeing in other parts of the world where social prescribing has been implemented, and that includes increased quality of life for seniors, a decrease in emergency room and physician visits, individuals being able to remain at home longer, stronger connections to community, an increase in physical and emotional well-being, as well as discharge from hospital sooner with a smoother transition back home. Next slide. What I want to focus on in these next few slides are results of a series of co-creation sessions that we held in January through April of this year with our 20 community connectors. We wanted to have conversations with them about what they saw that worked, what didn't work, and how we see that these programs can grow and continue to improve over the next few years. So the learnings from the co-creation sessions for us will help to build and establish a best practice manual, as well as any future education and training that will help to support the existing as well as new connectors with future expansion into more communities. Next slide. So there's a high level of an agreement among all of the community connectors that successful social prescribing programs should include the following core elements. Facilitation of connections to needed community resources, and we've heard that from my peers on this webinar today. Co-creation of a wellness plan for people that required more intensive follow-up, ongoing follow-up and check-ins for participants with those wellness plans, as well as an assessment for triaging, for prioritizing participants if referrals exceeded the program's capacity. So we have since asked each of these programs to work with us or work on a learning and development plan. And that's really so that they can identify what they feel is truly going well within these core elements and where they would like to see improvements within their existing programs over the next year or so. We're going to review these along with them to determine what additional supports, so us as UWBC, for instance, can help, such as bringing in expert speakers, a lot of questions around how do we manage this beast of a health system that we have, and other tools and trainings like motivational interviewing techniques, training on communicating with compassion or trauma-informed care. And all of these things will help them to remain and be successful in their practice. Next slide. The community connector role, we've also heard them called link workers, wellness workers, navigators. This role really emerged as essential to the success of social prescribing programs. So programs with an experienced community connector who was knowledgeable about community assets, had pre-existing relationships with other organizations and providers in the community, generally reported more successes, receiving and making referrals. So furthermore, community connectors reported going beyond just making referrals, including offering additional supports to access resources, things like arranging transportation, accompanying participants on outings, and organizing or developing new resources or activities to meet the needs in their community. This suggests that there's potential for community connectors to play a broader role in supporting older adults or other participants in contributing to capacity building within their community. However, this also for us raises the possibility of overburdening the community connectors if they're not adequately resourced and supported. An important finding in our evaluation was the value of a community of practice and how community connectors benefited from the opportunity to share and engage in discussions with other connectors. Community connectors in the UK, for instance, have reported the benefits of shadowing others, suggesting that one-on-one mentorship or support may also be beneficial for less experienced community connectors. And furthermore, we've seen in the literature, it is warned about the potential stress and burnout that can occur when dealing with participants with those higher needs or those more complex individuals. And so it's important that community connectors receive effective training and emotional supports in their own personal journey. And then the literature has also showed us that when staff turnover occurs in the community connector position, it can take time to rebuild the community knowledge and relationships that were held by the previous individual. Next slide. I mentioned previously community practice. Another facilitator that was noted by the community connectors, the value of having a community of practice so that they could connect and learn from the challenges and successes of other social prescribing programs. A formal community of practice exists here in BC, where we bring the connectors together monthly, virtually, and provide opportunities a couple of times a year at least to meet in person. In the co-creation sessions, community connectors voice their preference that the community practice meetings should occur monthly or bi-monthly, be chaired by a content expert, and include regular open discussion and time, and in addition to regular structured presentations and activities. Next slide. A key challenge reported by community connectors was building relationships with family physicians to facilitate those referrals. Challenges receiving referrals from family physicians have similarly been reported in other literature due to lack of an understanding of what social prescribing programs and the lack of time family physicians actually had to engage. Indeed, gaining buy-in from family physicians and legitimizing social prescribing programs in the eyes of those healthcare systems have been identified as a key step in successful social prescribing program implementation. The most impactful strategy that emerged from our work in addressing the issue was cultivating that physician champion. So a strategy that has been identified in the research. And many of our connectors reported greater successes connecting with other healthcare providers, such as home and community care, mental health, and hospital discharge teams, where they were making those connections directly with the physicians. Next slide. And at the other end of the social prescribing process, some community connectors reported a lack of appropriate organizations and services to refer those older adults to. So the need for strong nonprofit and voluntary service sector to support social prescribing programs was reported. And some caution, there is a potential that social prescribing will increase the strain on nonprofit and voluntary services that are already struggling with capacity and downloading of responsibility from the health and social care systems. The high level of agreement, just about 70% of our connectors said that an assessment and triaging process for referrals was a core program element that was identified in order to ensure that they were meeting the needs of those that benefited most. So as I come to the end of my presentation, I'd also like to share that we are grateful here in BC for the support from our Ministry of Health, as well as local health authorities like Fraser Health for their ongoing support and commitment to social prescribing. We've just received a commitment to increase from 20 community connectors to between 90 and 100 connectors across our province over the next 2 years. And this commitment is a reflection of all of the hard work, the passion of the connectors that are on the ground, the evaluation that has been done, as well as the ongoing research and policy development from organizations like CIS that help to support us in this. In BC, our hope is that we'll continue to evaluate and learn so we can share our learnings in hopes that we continue to support this growing interest and movement in social prescribing across Canada. Because at the end of the day, it's all about Bevians out there and the impact that these programs have on their life. Next slide. So what happened to Bevian? In her darkest moments, a ray of light appeared in the form of Trina, her community connector. A compassionate hospital social worker referred Bevian to the program after a fall. Trina later became Vivian's advocate, helping her apply for government benefits, ensuring she received her old age security as well as the guaranteed income supplement. And thanks to Trina's support, Vivian's financial situation stabilized and she felt more empowered. She also received grocery deliveries from a food bank, housekeeping services from a local United Way supported Better at Home program. And with Trina by her side, Vivian found a lifeline and an ally. And she quotes, "She is the first person I come to if I'm ever in trouble." And with that, I thank Vivian for sharing her story, Trina and all of the connectors out there, navigators, link workers who are making a difference each and every day. Thank you.
Wonderful. Thank you so much, Bobby. And thank you to Connie and Dina and Pat for wonderful presentations and so great to hear what's happening across the province and in so many different and unique ways. I'm going to transition us into our Q&A and discussion portion of our time together today. And we have a couple of questions that I'm going to ask the panelists, and we'll open it up to a couple more questions in the Q&A. We've been trying to do our best to respond as those have been coming in, but would love to also have a discussion around some of those questions. So the first question I have here for the panel are, what are some of the barriers to implementation in your respective provinces? So I'd love to start with Dina and Pat, and then Connie to speak a little bit more around some of the challenges you may have encountered over the course of your work.
Thank you so much, Rodano. So in element of time, I'm just going to highlight a few things so I can share with my amazing co-presenter, Pat. But in terms of our barriers to implementation, the biggest one for us has been outreach, because a lot of our primary care providers and healthcare providers, well, they are interested in the concept. We're told often that they're too busy, and we're always looking at how to make things easier for people to refer. And when we look at our referrals across the province, over 50% of them are not coming from physicians. They're coming from allied health professionals. They're coming from social workers, dietitians, case managers, other people. And we're always sending out that message and doing outreach. But a huge barrier for us is getting that information out to the right people and showing them exactly how easy it is. It's one page to refer, and then the Senior Active Living Center takes it from there. So we're trying to make it as easy as possible by participating in the Links to Wellbeing Project in Ontario as well. The other barrier has been finances, and a lot of centers still do have a membership fee. They're able, through a private donor who was very generous, able to receive free membership, free programs if they need art supplies to attend that program. So that barrier can be removed. But again, that's information that we're always sharing and trying to communicate with our healthcare partners so they know it's easy, it will help you, and it will reduce the visits and lead to a better quality of life for them. I'm going to turn it over to Pat now.
Thanks, Dina. Actually, my head was in the same place as your head, because that was what I was going to say right from the get-go, and it continues, is that challenge in reaching primary healthcare providers and converting a general interest, as Dina alluded to, into actually making that referral. So we're always working at developing more and newer tools that we think will reach some of those providers. But I think we need to do a lot more to show them what the benefits are to them as well, and how that might, benefit their practice. So, because people will look at it as, how is it going to help us as well? I think we've gained traction, though. Remember, we started this project, Dina, during that first year of COVID. And so little by little, we're gaining, I think, a lot. We've also looked beyond the traditional suspects, just the physicians. So we're making great strides with community paramedics, and we're beginning to make some really good strides with the community pharmacists as well. So we're thinking more broadly, wouldn't you say, Dina, over the years, about where do older adults go? Who are the trusted professionals for them in their community? And in some cases, they might know the pharmacist, for example, better than they know the family doctor. So I would say that would be the one that's been kind of ongoing. And I noticed that Joe in the chat mentioned the Ontario Community of Practice. If you join there, that's where we look at some of these things together with others in the province and beyond, and really try to problem solve.
Wonderful.
Just before you move on, Jordanos, I think there's a great comment. I think I've lost it now. but of a healthcare provider who said they didn't know about it. So that's part of it as well. You can't access what you don't know about. And so I think that's going to be just an ongoing part of what we do. And eventually everybody's going to know about this.
Wonderful. I love these responses. It sounds like there are some challenges, but there are also so many ways that we're working towards addressing them collectively. So thank you so much, Dina and Pat. Connie, anything you wanted to add around barriers to implementation?
The biggest barrier from our end is the my lack of awareness of the number of layers in healthcare providers. We were at a meeting recently with healthcare providers, and we were given recommendations of 3 more groups because social prescribing is so powerful, so needed, and that there were 3 more networks that I didn't know existed. And so the list that we've seen today about pharmacists and paramedics and all of them, we need to connect to them because they are powerful. And in many cases, the older adult may have built up a trust there. Thank you.
No, that's great, Connie. And maybe over to you, Bobby, to share. I know you shared some of the barriers in your presentation, but what some of those facilitators might be from your perspective as well.
Sure. So we started very intentionally back in 2020, where in one particular region, we aligned with the health authority. So when we were rolling out our social prescription model, we worked in tandem to ensure that there was a community connector in every community. And we chose the nonprofit organization in collaboration with the health authority and with the divisions of family practice. And so right at the beginning, before we even had connectors on the ground, we had communities that were ready. They were ready to refer, they were ready to prescribe, and the community-based resources were ready to receive. And then when the community connectors actually came in, they were set up for success. On the flip side, when we talk about barriers, there were other communities across the province where we just instilled a community connector. We said, here you go, here's some money, go to it. Yet there wasn't already that connection. The physicians were like, what the heck is social prescribing? We've never heard of it. COVID, it was during COVID. So they actually started doing things like just grocery delivery and prescription pickup for everybody in their community. But for us, the facilitator was the intentional setup, working in collaboration with the multiple stakeholders that were going to be part of that scheme before we even went in.
Wonderful. So it sounds like there's lots that's working and lots that can be shared and learned from across provinces as to ways to address some of these barriers. So I'm gonna keep us moving along with a follow-up question again on our end before we look to the Q&A. But we've talked a lot about collaboration and buy-in and working across sectors. Open to the full panel and whoever wants to respond. But what do you think collaboration could look like within your community? So beyond where it is now, and what you think some of these partnerships might look like and whom they need to be with?
I'm happy to start, and I'll start because we're right in the midst of it right now, because we are rolling out another 80 to 100 over the next 2 years. So we actually just came back from I just returned back to BC from a series of community consultations where we were actually going into communities and we were talking about what makes collaboration. What does that look like? How do we define collaboration? And who can we bring into our realm so that when the connector, we can say, do you want a connector? Are you ready for a connector? And what's that going to look like? And so for us in BC, it's the older adult. That is the target population that we serve. And so we were looking at who are your community-based organizations that are already serving on the ground? What municipalities, what are the community senior services that are out there? The food banks, the transportation, who all plays a role in mobilizing assets for seniors in that community, having them come to the table and talk about how they can work together. And then once that's established, we will say, and here's money for a connector, and how do we support you in ensuring that that person's successful?
Wonderful. And I'm just seeing a message in the chat that the keynote session is also starting. I think we still have 5 more minutes in this space. So if you do need to jump, that's okay. But over to Connie, Dina, and Pat, any thoughts around collaboration?
Absolutely. One of the things that we're looking at and it's been reconfirmed by listening to some of us today, is to take our age-friendly connecting days and bring social prescribing into them, because we bring together in communities across the province all the supports from the community. So now we're going to bring the healthcare provider, the paramedic, whoever, instead of doing 2 connecting aspects, we're going to do 1 and combine them both. Find out where all the services is that the healthcare provider through the resource coordinator can connect with, collaborate with. More collaboration, the more aging in place we're all going to do.
Wonderful. Thank you for that, Connie. All right, so I will maybe move to some of the questions that came up in the chat, but one is thinking of the title of our session today, so how social prescribing is transforming the landscape of healthcare in Canada. The question is, how far away are we in Canada from the UK in terms of adopting social prescribing more fully?
I think it varies. Here in BC, we're going to be lucky enough, hopefully, to have over 100 connectors helping seniors, continue to thrive in their communities and their homes over the next 2 years. We are lucky because we have the full support of our Ministry of Health and our health authority partners to fund those positions. There's a lot of work that needs to be done in some of the other provinces, and some provinces are trucking right along, as well as BC. So I think it varies depending upon the province or community and the target population. In BC, I'll say we are only looking at older adults because that's the funding pool. We could grow a lot more in BC. I'm looking at other age groups.
Wonderful. Connie, Dina, Pat, any thoughts on that question there, or? Perfect. Okay. I think
maybe just reiterating what Bobby said, that it's a difficult question to answer in some ways.
I think we lost Pat there, but we'll, hopefully she'll jump back on.
I keep getting bumped out.
Oh no. Okay.
That in Ontario, where we have many communities, so there is going to be the variation that Bobby talked about. But when Bobby was speaking, when you're speaking, Bobby, what I thought of was when I started in this area 4 or 5 years ago, I constantly quoted the UK. I constantly used UK people to refer to. I constantly used UK statistics. And when you said that, and when Jordanos asked the question, I realized that I've migrated to more often quoting what's happening in Canada. Mm-hmm. So I think that the UK was absolutely fundamental in getting us started. Mm-hmm. But I think over time, that gap.
That gap has closed, and people like the UK will be quoting us soon.
Yes, I think that is definitely the goal. Pat, do we still have you?
It's interesting just to observe. We have more, more that we can draw on from Canada now.
Wonderful. All right, so we have about 1 minute left, and maybe I just want to give anyone on the panel a chance to say any final words before we close out for the day.
Just thank you all for coming today. Thank you for your interest in social prescribing. The more that we continue to talk about it, the more, it will happen in these communities. And so keep trucking along. And I'm always here to talk social prescribing if anybody ever wants to reach out.
Wonderful. Thank you, Bobby. And with that, I see that we have all of the panelists' contact information in the chat. So again, do feel free to reach out. And thank you so much again for joining us today. And wonderful thank you to our panelists as well.